Hi, hello. Welcome back. Let's discuss a short case. 16-year-old child presented with primary amenorrhea. MRI was performed after a sonography. These are the MR images. Please write down your findings. The hyperintense structure is urinary bladder with low-lying hypointense echoes. Rest of the findings you please write down. And this is coronal T2 weighted imaging. Please write down your findings. This is axial T2 weighted imaging at the level of renal hilum. Please write down your findings. Yeah, what is the diagnosis at this point of time? So here in the first image, if you closely see, what I said is, this is the hyperintense bladder with the intramural echoes here. And if you closely observe the orange areas, the uterus is absent in the uterine fossa. So uterus is absent. You are not able to see the uterus. It is just opposition of rectal wall and the bladder here. Again, here you are able to appreciate this is the urethra, and you are not even appreciating the upper two-thirds of vagina. There is approximately 1/3 of lower vagina you are able to appreciate. So this is the lower 1/3 of vagina which you are able to see. And however, both the ovaries are normal. This is the right ovary, and this is the relatively distantly placed in almost in the left iliac fossa. This is the left ovary. So there is uterine agenesis, normal ovaries, and also there was absence of left kidney. These are all the classical features of Mayer, Rokitansky, Kuster, Hauser syndrome, which is a Mullerian anomaly in which Mullerian ducts fail to develop correctly. Mullerian duct anomalies are classified into 7 types, and type 1 is known as Mayer, Rokitansky, Kuster, Hauser syndrome, and it is characterized by uterine and upper 1/3 of upper 2/3 of vaginal agenesis with normal ovaries and fallopian tubes. MRKH is divided into 2 subtypes. Type A is isolated uterovaginal aplasia. Type B is associated with renal agenesis, like in our case, or you can see horseshoe-shaped kidneys or other abnormalities. Skeletal abnormalities like fused vertebra scoliosis can also be seen in our case. Those findings were not seen. It has an incidence of approximately 1 in 5,000 female births. The etiology of MRKH syndrome is unclear, and a lot of genetic causes are presumed. MRKH usually present with primary amenorrhea, like in our case, and the karyotype is generally normal. So best imaging is MRI. It also picks up normally the ovaries, like in our case, can be in very farly placed. You should be able to appreciate both the ovaries before calling it as a MRKH syndrome. These patients can have marital life following a vaginoplasty. They can get a McIndoe's vaginoplasty. They can reconstruct the lower 1/3 of vagina. These people are candidates for surrogacy, as you can definitely retrieve the ovum from the normal ovaries. Fallopian tubes also are normal. However, they can't bear the children, as uterus is absolutely absent. So you have to assess the degree of uterine development, including the ovarian location is the most important part of it. And MRI also sees the renal anomalies and skeletal anomalies. Thank you very much. Hope this short video on MRKH syndrome was useful for you.